So please start in three, two, one.
Okay, okay. Thank you. Thank you, Tech Team. So, good evening, speakers and everyone joining us today. It's a genuine pleasure and privilege and honor to welcome you all to Bayer Eyesight meeting. Today, we are conducting this meeting on DME and AMD. Our first topic is in DME from understanding to treatment. And the speaker is Dr. Dinesh Shunta sir. Sir is a young and promising ear surgeon from Dishai Hospital. And our second topic is NAMD, critical information for clinician to enhance patient outcomes. And the speaker is Dr. Shubhadeep Sarkar. Sir is also a young and energetic ear surgeon from Dishai Hospital. So today's both speakers are from Dishai Hospital. Thank you. So now I hand over the session to Dinesh.
Should I start?
Yes, sir. Yes, sir. You can start.
Voice is loud and clear?
Yeah, your voice is perfect, sir. Perfect. No issue with the voice, sir. Please check the slide deck, sir. It is working or not properly.
Hello.
Yes, sir. Your slide deck is yeah. Now it's coming.
Slides are visible in big screen?
Yeah. Big screen. It's
Okay.
in meeting view.
Slide show is visible, right?
Yeah. Slide is visible. Yes,
Okay.
please check that slide is changing or not, sir. Just check. Go to the next slide. Yeah. It's working. It's perfect.
Fine, right?
Fine.
So, good evening, everyone, and thanks for the opportunity. Dr. Dinesh here from Desai Hospital. So, my topic is diabetic macular edema from understanding to treatment. So, today we'll discuss diabetes and diabetes macular edema from A to Z, how it evacuates from very early till now. So we all know that the diabetes is the global burden right now and all over the world, and it is increasing day by day. For example, if you see that from the North America and Caribbean, it increases from 48 million in 2019 to 63 million in 2045. So there is near about 33% increase. And here we can see in the world map almost it includes all the countries, and it increasing from 2019 and expected to 2045. Almost all of the countries is going to increase a lot. Coming to the India, here we can see that the Southeast Asia in 2019 it is 88 million, and we are expecting 115 million in 2030 and around 153 million in 2045. So it's near about 74% increase. So right now it's really a good global burden all over the world. So what is DME? Diabetic macular edema is the presence of the excess fluid in the macular area of the retina, which result in loss of the visual function. DME occurs when blood vessels in the retina leak fluid and proteins into the macula, causing the macular swelling, which in turn affects visual function. And the VEGF-A plays a key role in the pathophysiology of the DME. How? VEGF-A increases vascular permeability and disrupts the blood-retina barrier in DME. So DME is the leading cause of moderate to severe vision loss in patients with diabetes and a leading cause of blindness in working age population in most of the developed countries. It can affect both type 1 and type 2 diabetes mellitus, mostly in type 2. My voice is clear, Abhishek?
Yes, sir. Your voice is perfect. It's perfect.
Thank you.
If there is an issue, I will inform you, sir.
Okay. So vision loss in patients with DME can have life-changing consequences. How? Here we can see in this slide, vision loss in DME can happens, and it leads to difficulties in performing near vision walks, difficulties in perceiving colors, daily activities like difficulties in driving or license revoked, difficulty in reading, and all this leads to depression because of the loss of the vision. So these patients with DME are typically of the working age. So vision loss that reduces independence, productivity, and the ability to perform daily functions can have their drastic impact on their lives. Most important, mental life. So if DME is not treated, it can lead to severe visual impairment. Here we can see in the paragraph that it's a macular, normal macular photograph, and here is a macula of the DME. So DME can occur in individuals at any stage of the diabetic retinopathy, whether it is NPDR, whether it is PDR. And this badly controlled diabetes and untreated DME can lead to severe visual impairment and blindness. Here in the photo of the retina, here we can see that the yellow circle is showing the macroaneurysms and the intraretinal hemorrhages, and the red circle showing lipid exudates often distributed in a succinate pattern. So the treatment of the visual impairment due to DME has evolved over time. How? Let's go back to 1985 ETDRS study. That time laser was only the choice. It was a gold standard. But in 2011, ranibizumab was first approved for DME in 2011 with the help of the study Rise and Ride and Restore. Then in 2012, with the help of the FAME study, fluocinolone acetonide was approved in 2012. Coming to 2013 and 14, with the help of the MADE study, dexamethasone was approved, and most important, with the help of the VIVID and VISTA, a remarkable study, aflibercept Eylea came approved for DME in 2014. Now, recently, faricimab was approved in 2022, and most recently, aflibercept 8 mg was approved in 2023. So nowadays, anti-VEGF is the current standard of care for visual impairment due to DME. So let us know what factors drive key mechanisms behind the pathogenesis of the DME. So here in the here with the help of this picture here we can see that VEGF-A and PIGF act via VEGF receptors to promote vascular leakage and edema and inflammation and neovascularization. VEGF-A acts via VEGF-1 receptor and VEGF-2 receptor, whereas PIGF acts both directly via VEGF-1 receptor and indirectly by VEGF-2 receptor by displacing VEGF-A from the VEGF receptor 1. So this excessive activation of the VEGF-1 and VEGF-2 receptor can increase in vascular leakage and edema and inflammation and pathological neovascularization. So this vascular leakage and edema and inflammation are the key mechanisms that drive the pathogenesis and the progression of the DME. Very well explained in this paragraph, with the help of this diagram, that the vessel occlusion, whether due to BRVO or DME, which leads to impaired retinal flow and which leads to the hypoxia. And this hypoxia activates VEGF-1 and VEGF-2 receptor, which leads to vascular permeability, breakdown of the blood-retinal barrier, and which leads to vessel leakage and edema, that is diabetic macular edema. Hypoxia also leads to inflammation and which leads to RP cell damage, which again vessel leakage and edema happens. And the last, neovascularization happens, which is the last stage. So aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of the retinal disease. Here we can see that ranibizumab only targets VEGF-A. Brolucizumab only targets VEGF-A. But aflibercept targets all the three, VEGF-A, VEGF-B, and PIGF. Even if VEGF-A is completely blocked, VEGF-B and PIGF would still be able to bind the receptors and therefore contribute to downstream pathological effects. So for better treatment, we need a molecule which binds all these three receptors. Coming to the summary, VEGF-A, VEGF-B, and PIGF are key drivers behind the pathogenesis of the DME. And aflibercept is the only globally available anti-VEGF agents that targets multiple mediators of the retinal disease. So, what are the sources of evidence support anti-VEGF choice for the patients? That could be randomized controlled trial, that could be real world evidence, that could be network meta-analysis, that could be international guidance, that could be mode of the action, or our own experience. So it is important to provide timely and effective treatment for all patients with DME for the long-term treatment. So let us know, what did Vivid and Vista show about impact of the aflibercept in the DME. Here in this, with the help of this the chart, here we can see with the bar chart with the graph, here we can see that the Vivid and Vista, the main remarkable study, clinically meaningful vision gains were achieved in patients who receive early intensive treatment with aflibercept. So what do you mean by the intensive treatment? That initially we used to give the loading dose 3 injections, but intensive treatment, that is give the loading dose 5 loading dose. So that is called intensive treatment. So here we can see with this chart that 5 injections were given both in the Vivid and Vista as a loading dose, and then we have continued. So the gain in the visual, the gain in the letters were much more, that is more than 10 letters in both of the studies at the end of the 1 year. So this Vivid and Vista and Protocol T, clinically meaningful vision gains were achieved in patients who receive early and intensive treatment with aflibercept. So Protocol T have also said the same thing, that the vision gains were observed as early as with the first aflibercept injections. Patient received more than 8 injections through 1 year and maintained those vision achieved during the initial loading phase throughout the year. Across all the 3 studies, patient treated with aflibercept gained more than 10 letters, and at the week 52, that is at the end of the 1 year, aflibercept demonstrated superiority to laser in Vivid and Vista study. So let us see, if we don't give the injections in early and intensive phase, we are giving the injections later on. So how it affects our vision and patient profile. So Vivid and Vista study have also seen that if we delay the aflibercept treatment, so how much it costs to us. For example, here we can see in both in Vivid and Vista, this white line is a laser one. So after the week 100, those laser patients were given aflibercept injections in a PRN basis. So in both of the studies, here we can see that patients in the laser group receive aflibercept PRN, SPRN from week 100. They have got quite loss of the vision gain. So 48 and 46% of the laser control eyes receive aflibercept PRN from week 100 have shown the patient didn't gain so much vision, just like the initially from this row here we can see the blue line and the yellow line, that the patient who have taken aflibercept injection from the earlier have got vision gain near about more than 10 letters, whereas in patient with the laser have gone only 1.5 or 1.6 letters. So there is, it's very much cost the vision of the patient. What do meta-analysis and expert international guidelines recommend for the treatment of the DME? A Cochrane meta-analysis reviewed evidence from major studies investigating the efficacy of the anti-VEGF agents in DME. Here we can see that the methods: systemic meta-analysis of the RCT, providing a level 1 evidence-based review of anti-VEGF agents. It included 24 studies, more than 6,000 patients with DME, and vision generally between 20 to 200 and 20 to 40. So what they conclude, that year 1, all efficacy outcomes significantly favored aflibercept over the other drugs. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept compared to other molecule at the 1 year, and anti-VEGF did not differ regarding the adverse effects at year 1 or year 2 of the follow-up. Other meta-analysis suggests aflibercept is the most favorable treatment for the patient with the DME. And they have shown that the aflibercept Q8 interval consistently showing evidence of superiority over the other molecule like ranibizumab, 0.5 milligram PRN for mean change in BCVA and gain of the more than 15 ETDS letters from baseline to month 12. So aflibercept is the most favorable treatment in terms of the BCVA improvement or CMT reduction compared with the other therapies in the management of the DME within 12 months. So international guidelines and recommendations also suggest aflibercept should be the drug of the choice in patients with a DME with BCVA less than 69 letters, or that is 20/40 or worse. So here we can see whether it is EURETINA guidelines or whether it is Asian recommendations or whether it is Diabetes Canada guidelines or whether it is German Ophthalmology Society guidelines. All we are saying that the aflibercept is the drug of the choice in the DME patients. So can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? Let's see. So these are the data from the Moorfield Eye Hospital and the FRB registry, which shows the efficacy of the aflibercept in patients with clinical practice. So they have shown that the aflibercept compared to other molecule giving the more vision gain compared to the other molecule. So this with the help of the bar charts, they are saying that the aflibercept by taking the aflibercept gain was significantly higher in the aflibercept than compared to the other injections, and the number of the injections we are taken was quite less. Here is the other study called the VIVIM study. It is a treat and extend study with aflibercept initiated in year 1. But after the year 1, we have started treat and extend, and they provide meaningful vision gains at the year 2. So they are saying that the 57% of the patients were on the Q12 intervals, means 12 fixed intervals at the end of the year 2. There is another study called Hirano et al. Saying the same thing, that the majority of the patients with DME achieve 16-week treatment interval with an individualized treatment action regimen with aflibercept. They have also initiated after the 1 year. And here they have shown that the 67% of the patients were on Q16 interval. Q16 is quite a big deal after the end of the year 2. JED study have also shown that after the 5 monthly loading doses, if we switched into treat and extend regimen, here they have also shown that the patients were quite maintained. So overall, coming to the summary, we can conclude that aflibercept can achieve meaningful vision gains in patients with DME as demonstrated by the RCT. Meta-analysis and international guidelines and recommendations also suggest aflibercept should be the drug of the choice in patients with the DME with baseline vision acuity 20/40 or worse. And also the real-world experience highlights the effectiveness of the Eylea in the clinic when patients regularly present with poor vision acuity that is less than 69 letters. So if in a clinical practice, patients come with the DME with the visual impairment, particularly those with the BCVA less than 69 letters or 20/40 or worse, can achieve meaningful vision gains with aflibercept compared with the other anti-VEGF agents in real-world clinical practice if we start early and if possible goes with the extensive treatment, and later on if we switch the patient into treat and extend regimen. Thank you. Thanks for the hearing.
Thank you, sir, for a wonderful presentation. I think
I have a question, Dr. Dinesh.
Yeah, sir, you can.
Sir, actually, how do you practice in your real life? In real practicing scenario, how do you practice? Whether you use aflibercept in naive cases or in recalcitrant one?
So basically, frankly speaking, in my daily clinical practice, if patient can afford aflibercept, or for example, those patients for like the CGHS or WBHS, I usually go with the aflibercept. And whether I use any anti-VEGF, I always give loading dose at least minimum 3. And Abhishek also knows that I presented this study, I think 6 months before. So after this study, I generally nowadays I'm trying to give the intensive treatment, that is 5 doses, if patient can afford. And my first choice will be always in and that is Eylea from my fellowship days.
Okay, thank you. Thank you. Thank you, Dr. Dinesh.
Thank you, Shubhadeep sir. Thank you, Dinesh sir, for your trust
Thank you.
with the aflibercept, with what you have expressed with the aflibercept with your patients. So thank you once again. And
Thank you.
now our next topic is next speaker is Dr. Shubhadeep Sarkar. Now I hand over the session to Dr. Shubhadeep sir.
Okay.
Subhadev is there.
Yeah, sir is there.
Yes, I'm there. So let me share my screen.
Yes, sir. First thing, share. Dinesh sir is stop sharing.
Sir, click on share screen button.
Yeah. It is coming.
My
Sir.
slides are.
Yeah,
I
yeah.
have stopped sharing, right?
Right. Sir, screen is visible.
My screen is visible now?
Yeah. It is visible, sir. Now just you have to do the presentation mode.
Okay. So, good evening, everybody. And at the outset, I would like to thank Bayer for this opportunity. So, today I will be sharing critical information for clinicians to enhance patient outcomes in neovascular AMD. So, to discuss it, I have to go through and explain one of the finest study done for aflibercept is PLANET study. So, today we will review the PLANET study, a landmark trial evaluating aflibercept in PCV. We will cover design, outcomes, comparisons, and implications for clinical practice. So here is the study overview. This was a robust multi-center study across Asia Pacific, Europe, and Australia. Over 300 patients were followed for 2 years, giving us long-term uh, insights into aflibercept role in PCVs. That is almost 2 years or 96 weeks. So the main goal was visual acuity improvement. Secondary endpoints focused on whether rescue PDT added benefit in suboptimal responders. Now the treatment arms, patient received aflibercept as monotherapy with a loading dose followed by every 8 weekly, with PDT reserved only for those not responding adequately. This design reflects real world practice where we avoid overtreatment. Now the vision outcomes, you can see this is a chart where the vision outcomes in both the scenarios where aflibercept monotherapy and aflibercept with rescue PDT at 96 weeks, it is almost 10.7 liters gain. Now rescue therapy is only required only 15 to 80% with PDT. 80% of the patients are managed well with aflibercept. 80% had inactive polyps at 52 to 96 weeks, and there is complete regression. Complete regression is quite lower, while what matters is the vision stability most. Now, coming to the treatment burden decreased significantly in year 2, with many patients extending to 12-week intervals, a practical advantage in real world care. That is, in the first year, almost 8 injections were required. In the second year, the injections came down to 4 to 5 with treat and extend regime, and 41% achieved more than 12 weeks intervals. Now, safety findings were reassuring, consistent with what we already know about aflibercept. So, no new safety signals required. Now, comparing with Everest 2 study, compared to Everest 2, PLANET demonstrated superior outcomes with less reliance on PDT. This underscores aflibercept's efficacy in PCV. Clinical implications. The takeaway is clear. Aflibercept monotherapy should be the standard of PCV. Rescue PDT is rarely needed and adds little benefit. And in the conclusion, Planets establishes aflibercept monotherapy as a highly effective, safe, and practical approach for PCV and management. So here is a simple flowchart. You can see 3 monthly loading doses every 8 weeks interval. Assess the response after 2 weeks, 12 weeks. If there is improvement, continue aflibercept, treat and extend, and see whether the patient is maintaining vision and it lowers the treatment burden. If there is no response or no such improvement seen after 12 weeks, add rescue PDT, target active polyp monitoring, and adjust therapy. These all leads to achieve stable vision and inactive polyps. Now, alter study supporting the findings of Planet study. So here the study design, it's a phase 4 randomized open label multicenter, 40 sites in Japan, 255 treatment naive patients more than 50 years with wet AMD. 2 treat and extend regimes, 2-week interval adjustment and 4 weeks interval adjustment. Duration is almost 96 weeks. Objectives primarily efficacy of aflibercept with treat and extend regimes, and secondary safety over 96 weeks. Endpoints: primary BCVA change at 52 weeks, secondary more than 15 ETDRS letter gain, CRT change, vision maintenance and fluid-free OCT, injection frequency and intervals, and safety outcomes. Visual outcomes: rapid rapid best corrected visual acuity gains in year 1 maintained through 96 weeks. There is mean BCVA gain plus 7.6 letters in 2 weeks interval group and plus 6.1 letters in 4 weeks interval group. That is almost 30% gain in more than 30% of the total patient gain more than 15 ETDRS letters. Anatomical outcomes: CRT reduction achieved in year 1 sustained through 96 weeks. So injection burden reduced. In first year it is almost 7 injections. In the second year it is 3 to 4 injections. Mean total injections over 96 weeks is 10.4, and 55 to 57% of the total patient received less than 10 injections. Treatment interval in 1 year, that is almost 57% reached more than 12 weeks intervals. In week 96, almost 57 to 60% maintained more than 12 weeks interval. 42 to 46% of the patients achieved maximum of 16 weeks interval. Safety: there are treatment induced adverse effects consistent with aflibercept profile. Common ocular adverse effects are cataract, conjunctival hemorrhages. There is few serious adverse effects, though death is not related to this study. Conclusions: both regimes effective and safe. Vision gains and CRT improvements sustained over 2 years. Reduced injection burden in the year 2. Majority achieved extended dosing intervals 12 to 16 weeks. Supports proactive treatment and extend aflibercept regime in wet AMD. So this is a simple flow chart. You can see the study design: 2 weeks treat and extend method and 4 weeks treat and extend method, 96 weeks, 255 almost wet AMD patients. Key endpoints: you can see that BCVA change more than 15 letter gain, CRT reduction, injection frequency. Results: that is almost 7 points, plus 7.6 to plus 6.1 letters, 10 injection on an average injections. 57 to 60% of the patients requires more than 12 weeks interval. 46% of the patients are on 16-week interval. So conclusion: sustained vision gains, fewer injections in year 2, and extended treat and extend intervals. So thank you.
Thank you, sir, for a wonderful presentation. So then now the session open for the audience. If they have any questions, especially request for Dinesh sir. If you have any questions or any kind of opinion from your end, you can share.
Hello.
Yeah, you are audible, sir. You are audible.
Did I miss something?
Yeah, you are
Yes,
audible and visible.
No, I didn't hear the question actually.
So whether you are likely to ask any question to me about
or
this
any
study,
opinion, any opinion,
or any opinion
Yeah,
you would, or
obviously,
suggestion?
obviously, the first question will be, what's your daily practice means what you prefer in your OPD?
See, daily practice, it is on every time. What I do is I prefer a loading dose, at least 3 loading dose. Then I go for treat and extend regime.
Yeah, loading dose is very much important nowadays. It's very much important to
Without
bring
loading dose,
the
there is we can't achieve the desired result.
yeah. So after that, you prefer treat and extend regimen, right?
After loading dose,
After loading dose.
yes.
Okay. And
Sir, you-
and choice of the molecule?
Obviously, in whether if the patient is having some financial crunches, then I go for biosimilars or ranibizumab. Otherwise, I always prefer aflibercept.
Aflibercept. Yeah, it's a really good one and remarkable benefit.
Especially in
But
the health scheme patients, they really get benefit nowadays.
nowadays, so no problem at all. In fact, nowadays they have also reduced their cost also.
Price also, yeah.
So it's easy for the patients actually. Instead of giving, I think 50,000, 30,000, right, Abhishek?
we are 35 the package in
35.
India.
35,000, yeah.
So we are also working on that so that we can reduce further the price
Yeah.
on market.
Good, very good. It will be
Yeah.
And
So
most
that,
probably, I think this 8 milligram is also coming on the way.
yeah. In the this year at the late of the like we are expecting in September, October, we'll launch our 8 milligram. So we have
I
already
think after that, PSP program will start again, right?
hopefully with the 8 mg we have some PSP program will be there. It is already in launch before 3 years back. We already launched in USA and Europe, and we have a study that you can extend the durability up to 6 months with the 8 mg. I think that you have a main challenge with the compliance, like to the therapy. It's a big challenge for the patient who are treating with the anti-PGL. So if you can treat the extend durability up to 6 months, I hope it will be more helpful for you also, so that you can treat with the new patient, because we have already loaded with the old patient. They have to do frequent visit. So if you can extend the durability up to 6 months, so it will be like helpful for you and your patient both way. Will be, I think it will be helpful for both way.
The chance of coming in this year?
Yeah. This year, at the late of this year, we will launch this.
But before that, I think you need this DCGI approval, right?
Yeah, that we are working on that, and as you know that India,
That is going on?
Yeah. We have the approval with the US FDA, but still we are struggling with the DCGI approval. So you can understand what is the process for DCGI approval.
So without DCGI approval, we cannot use in India if it is an FDA approved?
We are claiming that it is US FDA approved, but DCGI approval is like you are getting the license to marketing in the India.
At least one indication.
Yeah.
At least.
Yeah.
So and for the other indication, we can use as an off level.
Off level.
At least one indication you need. We need.
Yeah. So that is the way we are working on that, and hopefully that will be changed. I think that will be changed already the treatment pattern also. So you can understand if a patient require only 2 injections in the year, so it will change the total scenario of the anti-PGL. We believe that.
Good. One more molecule in the bucket list.
Yeah.
Let's see.
Yeah. So thank you once again. Thank you audience, and thank you our respectful speakers for your valuable time,
Thank you.
and for your wonderful presentation. Hopefully in future we are doing more.
Definitely, why not?
We'll do more.
Thank you, sir.
Okay.
Thank you.
Okay,
Good night. Good night.
Bye, Saurabh.
Bye, Dinesh.
So I'm requesting the technical team, please, of this session link.
Okay.
Okay, sir.
Yeah. Just.
Okay.
Yeah. Okay.